Good morning, everyone. Today's topic for presentation is periodontal pocket and its disease activity. So, what is this periodontal pocket and disease activity? So, loss of attachment produced by periodontal disease was thought to be uh, important and is observed to be slow but continuously progressive phenomena. And more recently, as a result of studies of the specificity of plaque bacteria, the concept of periodontal disease activity has evolved. So, according to this concept, the periodontal pockets go through periods of exacerbation and periods of quiescence as a result of episodic burst of activity followed by periods of remission. So, periods of quiescence are characterized by a reduced inflammatory response and little or no bone loss and connective tissue attachment loss. So, a buildup of unattached plaque in the pocket with its gram negative motile and anaerobic bacteria, they start a period of exacerbation during which the bone and connective tissue loss and deepens the periodontal pocket. And these periods last for few days to weeks and months and is followed by periods of remission and quiescence. So during this periods of remission and quiescence, so there is something called gram positive bacteria which proliferate and more stable condition is established. So the periods of quiescence and exacerbation are also known as periods of inactivity and periods of activity. Active lesions and inactive lesions. So clinically, active periods are associated with bleeding on probing and gingival exudate, whereas inactive lesions are not associated with bleeding on probing. So that signifies whether the areas are active lesions or inactive lesions, progressive lesions or non-progressive lesions. So one more, the next important aspect what you need to understand in periodontal disease activity site specificity, because the periodontal destruction does not occur in all parts of the mouth at the same time. So that signifies that it has got a specificity of the area which is involved. So periodontal destruction does not occur in all parts of the mouth at the same time. As it occurs on few teeth at an inactive or active, it is termed as specific site specificity of periodontal disease. And one more, the next important aspect is pulpal changes in periodontal pockets. Pulpal changes associated with periodontal pockets cause spread of infection from pockets and may cause pathological changes in the pulp, such as such changes may give rise to painful symptoms and, and sometimes sensitivity also. And this involvement occurs through either apical foramina, lateral foramina, or pulp canals after the infection reaches them. And the general changes which are associated with pulp in associated with periodontal pockets. So atrophic changes and inflammatory changes are generally seen in few cases. And the next important aspect one need to understand is relationship of attachment loss and bone loss to periodontal pocket. So what do you mean by attachment loss? Attachment loss signifies, or it's a measure from cemento-enamel junction till the base of the pocket or base of the sulcus, because all the time you need not have a pocket. So what does the pocket signify? Pocket is the measure from crest of the marginal gingiva till the base of the pocket. So pocket of the same depth may be associated with different degrees of attachment loss, and pocket of different depths may associate with same amount of attachment loss. So areas between the base of the pocket and the alveolar bone is always constant, and the radius of action of the plaque bacteria is measured to be between 0.5 to 2.7 millimeters. So as you can notice in this particular picture, uh, in figure A, there is gingival pocket measuring about 3 millimeters, because the first band is into the from the marginal gingiva till the base of the sulcus. Gingival pocket with no gingival recession associated, whereas B signifies the periodontal pocket with similar depth, that is 3 millimeters, as shown in part A, but with some amount of gingival recession, whereas figure C signifies the pocket depth as shown in part A and part B, that is 3 millimeters, but associated with more amount of gingival recession. So cement enamel junction, if you see here, there is 2 millimeters of cement enamel junction exposed, and the pocket depth measuring from the crest of the marginal gingiva till the base of the sulcus is about 3 millimeters. So 2 plus 3 is supposed to be 5 millimeters of attachment loss. And the next figure, the present picture shows different pocket depths with same amount of attachment loss. So attachment loss is from the cement enamel junction till the base of the pocket, and the distance between the arrows and cement enamel junction remains same despite a difference in the pocket depths. So the first picture, where you can see, say, suppose about 5 millimeters of pocket depth is measured, that is from the crest of the marginal gingiva till the base of the pocket, whereas in the second picture you can notice the base of the pocket is constant, but the cement enamel junction is exposed. So the pocket is measuring only 1 millimeter, but there is about 4 millimeters of gingival recession associated, whereas picture C, figure C, represents more amount of, there is about 5 millimeters of gingival recession, but there is no pocket associated in this particular picture. So this signifies the attachment loss with or without association with periodontal pocket. So this particular figures, you can notice different depths of pockets and different attachment loss at 0 millimeters of pocket depth with 3 millimeters of probing depth, whereas second figure, which shows 1 millimeter of attachment loss and 2 millimeters of pocket depth. So what does that particular thing mean? So 2 millimeters of pocket depth minus 1 millimeter of attachment loss and the third picture shows 4 millimeters of attachment loss and 2 millimeters of probing depth, that is around 4 millimeters of attachment loss is recorded, whereas the next figure shows 7 millimeters of pocket depth, out of which 3 millimeters of attachment loss is seen. Fourth picture shows 3 millimeters of attachment loss and 3 millimeters of periodontal pocket. 3 millimeters of attachment loss and 0 millimeters of probing pocket depth. So to understand, one needs to have an idea about the definition of a pocket. Pocket is measured from crest of the gingival margin till the base of the pocket, and loss of attachment is measured from cement enamel junction till the base of the pocket. So areas between base of the pocket and alveolar bone. Normally the distance between the apical end of junctional epithelium. Apical end of alveolar bone is constant, and the distance between the apical extent of calculus and the crest of the alveolar bone in periodontal pocket is also constant, and the mean length which is measured in the studies is about 1.97 millimeters. The distance from attached plaque to bone is never less than 0.5 to millimeters to, and never more than 0.2 never more than 2.7 millimeters, which is supposed to be uh, a disease activity where the disease spread of disease can occur. So this signifies the bone resorbing activity induced within these particular distances, and the bacteria in connective tissue and bone may modify these considerations. So coming to next aspect, that is relationship of pockets to bone. Suprabony pockets, where the base of the pocket lies coronal to the crest of the alveolar bone, and the pocket wall lies between crown and the bone, and it is generally associated with horizontal type of bone loss. So you can see the arrows signifying the base of the pocket, horizontal arrow, and vertical arrow is signifying the level of rest of the alveolar bone. So that gives, by definition, the base of the pocket is coronal to the crest of the alveolar bone. So relationship of infrabony pockets to the bone. The infrabony pockets signify the base of the pocket, where the base of the pocket lies apical to the crest of the alveolar bone, and the pocket wall lies between the tooth and the bone, and it is generally noticed generally associated with vertical type of bone loss. The horizontal arrow is signifying the base of the pocket, whereas vertical arrow is showing the crest of the alveolar bone. So the base of the pocket is apical to the crest of the alveolar bone, is infrabony type of pocket. So coming to summarize the disease activity, so one need to understand what is disease activity, and periods of exacerbation and quiescence, and progressive disease and non-progressive disease, active disease and inactive disease, site specificity, and pulpal changes associated with the pocket, and what is the definition of attachment loss and periodontal pocket. Thank you.